Welcome to AETCM, the Emergency Medicine channel. Today we'll be discussing a young male patient who presented here with complaints of right lower limb pain. So, a 32-year-old male patient came to here with complaints of right lower limb pain and edema. It was since there for the past 2 days, but worsened that day evening. So, he came to our ED. On my initial 10-second assessment, he was conscious, oriented, and open to make amends. He went to the primary survey. He had a patent airway. There were no signs of any obstruction. Breathing part, he had a respiratory rate of 18 per minute and maintained a saturation of 98% in room air. He had adequate and equal chest excursions, and bilateral chest was clear with no added sounds. Circulatory part, he had a heart rate of 92 per minute and blood pressure was 130 by 90. Disability part, he had a full score of GCS and a pain score he complained of 6 out of 10. At this point, we secured a IV line and put paracetamol 1 gram IV was started. And the exposure part, his temperature was checked and was found to be normal. As adjunct to the primary survey, we took an ECG. It was showing 88 beats per minute with no other significant SCD changes. And on reassessment, his airway, breathing and circulation is maintaining, and the pain score has come down to 3. So we went to the secondary survey. Basically, the history is like he mainly came with complaints of right lower limb edema and pain since 2 days. And the previous history is basically he had a history of RTA about 4 weeks back. He was traveling on a two-wheeler and he was hit by a car. His primary injury was on the on the left lower limb, and he had a crush injury with great toe crush injury with undisplaced distal phalanx fracture. For that, he underwent plastic surgery and he was actually on bed for about 10 days. And after recovery, he was actually clinically better. But since about 2 days, he started developing this pain on the opposite limb. And then he doesn't have any non-allergic history and he's not on any regular medications. And on arrival that day, his last meal was about 6 hours back. And the only event that can actually maybe have contributed to this event was maybe his history that he was actually more of a bedridden for the past 10 days. That's the only history we have. Clinical examination, he was conscious oriented. System examination, again, respiratory, cardiac, everything was within normal limits only. Even to the local examination, in the local examination, the right lower limb was found to have edema, and erythema was present up to the right knee, and the right calf there was tenderness was present. And with this clinical findings, we are suspecting in more in terms of DVT or maybe some cellitis. There was no history of any direct trauma recently to the leg, or there was no history of any insect bite or anything like that. As from history, there wasn't any. So considering his symptoms, actually, we went ahead with a Doppler scan of the leg, and it was showing a deep vein thrombosis with a thrombosis affecting the common femoral vein, short femoral vein, popliteal vein, and caudal vein. And the thrombus was extending up to the right external iliac vein. And with this, this was the finding we got from the Doppler. So considering symptoms,
before that, what are the differential diagnoses you will have in a patient who is having pain, tenderness, redness in the lower limb?
The most common actually we have to think about is cellitis.
Cellitis. Most importantly, cellitis. Then
any lymphedema or any lymphatic.
Previous lymphedema, again cellitis.
Then
peripheral vascular occlusive disease. In that, normally you don't have tenderness. You get gangrene. Gangrene only, not tenderness.
Any osteomyelitic.
Osteomyelitis. In a trauma patient, recent history of trauma, now he is coming with cellulitis or cellulitis like picture. You have to always think about osteomyelitis. Okay. An insect bite. Okay.
This patient, he didn't have any history as suggestive of any of the features that can contribute to an acute infection.
Okay. Gout also most of the time present with tenderness, pain, redness, especially in the lower limbs.
Also, this patient didn't have any history of any fever or anything in the recent past few days. So actually, in case of DVT, actually we have a scoring system known as the Well score for DVT, which we can actually use to predict any possibility of DVT. In which actually the components are, there are different things we consider, and if the point is 2 or more, the DVT is likely, and less than 2, DVT is unlikely. So the score complains mainly of any active history of cancer since past 6 months, or any history of any paralysis or any recent paralysis or anything in the lower extremities, which may lead him to immobilization in the recent past. Then whether he was bedridden since past 3 days, or any major surgery within the recent 12 weeks, or any calf swelling that is at least more than 3 centimeters compared to the opposite side, and also any previously documented DVD of the same leg, and any alternative. Suppose each of this will have 1 point, but if the patient is we are thinking about a diagnosis which is as probable as DVT, it will have negative 2 points.
Okay.
And considering all these points and we add up and we are getting a value of 2 or more, we have to think more in terms of DVT.
Okay.
And suppose the point is less, DVT is unlikely. Suppose the point is less than 1 or less, initially we can go for testing like D-dimer. And suppose the D-dimer is positive, then there is again a more chance of DVT. And it's negative, it has got a very high negative predictive value of not having DVT.
What are the other conditions you get D-dimer positive?
The
Other
most
conditions.
Renal failure, sepsis,
Okay.
pulmonary embolism,
Pulmonary embolism, myocardial infarction,
infarction.
sepsis, any infection, inflammation, D-dimer can be elevated. So it's not a good test for its positivity, but for its negativity rules out DVT or pulmonary embolism.
So in our patient, initially we went ahead with USC Doppler because it was a more chance of.
On USC, what you observe in this patient? Ultrasound, compression test.
A compression, basically in a normal, if you're doing USC in a normal patient, the veins are compressible on probe. Where you're placing the probe, the veins are collapsible, but the artery stays non-compressible. But suppose we are having a DVT or thrombus within the vein, then it will also appear to be non-compressible structure.
But here Doppler is done.
Doppler is done. And considering actually the patient was a recent post-op patient, we actually advised admission and he was willing for admission. So we started him on enoxaparin.
So does this patient require admission or not? All patients with the DVT require admission.
Usually, suppose the patient is not having any significant complications like any chance of pulmonary embolism or anything, we can actually safely discharge the patient.
Okay. So all DVT, no need to admit the patient, we can even discharge the patient. Okay.
Suppose the patient is having DVT, we can also consider a criteria for risk stratification of pulmonary embolism.
Okay.
Because actually one of the most rare complications of DVT is again pulmonary embolism. In that we have something called Wells criteria, and in which suppose the patient is having signs and clinical features of DVT, it will give a +3 point. And any other alternative diagnosis is unlikely for this thing, then we give it again 3. And if the patient is presenting with a heart rate of above 100, then again we give 1.5. And in a recent immobilization, about more than 3 days, or in recent surgery in the past 4 weeks, we give 1.5.
What are the clinical findings of pulmonary embolism?
The patient may come with acute onset of breathlessness, and then we will be having a high desaturation.
That is in heavy, massive pulmonary embolism. It is mild.
Difficulty will be there. Then sinus tachycardia,
chest
Pleuritic pain. Pulmonary infarction can produce pleuritic pain. Then, like you told, breathlessness. Then tachypnea. Then
any unexplainable hypoxia.
Tachycardia, hypoxia.
Usually on fighting chest may be clear.
Chest will be ECG.
Sinus tachycardia will be
Okay.
there.
Mostly sinus tachycardia.
Then you want the RBBB, or even the classical S1, Q2, 3.
Okay. S1,
Q3, T3.
Q3, T3.
S1, S5 in the 1, and then in lead 3,
Okay.
Q3 and T3.
In all patients, you will see this.
No, about 30% or less.
About 30% only. Will see. Okay.
So in those kind of patients, actually we can even think about other chances of thrombosis, like any recent history of travel, any hormone therapy, or any recent accidents, and all we have to consider.
Okay. Here there is trauma, prolonged bed rest, surgery. Everything goes in favor of DVT. What are the other causes of DVT? Unprovoked DVT. What are the causes?
Smoking,
Smoking.
hypercoagulation will cause that virtuous triad will be there. So when
There is stasis, hypercoagulation, DVT. Okay.
of thrombosis
Okay.
there. Then any factor 5 leader mutations.
Common things. Common things first.
Like pregnancy.
Pregnancy.
Any hypercoagulable state can
What are
actually.
the hypercoagulable conditions?
OCP,
Common
OCP.
OCP, pregnancy, then
Smoking.
smoking, then malignancies, then polycythemia. Polycythemia is one important condition. Smoking related to polycythemia. Smoking also related to some other condition. What is it? Hyperhomocystinemia. Both. Hyperhomocystinemia can be congenital, can be acquired due to continuous smoking. But APLA syndrome. Okay, then SLE. Okay, protein C, protein S deficiency, antithrombin 3 deficiency, factor 5 Leiden mutation. So these are the common conditions. Okay. So a young patient coming here, we have a clear-cut history of trauma, accident, surgery. So we don't go to that side.
Other causes.
Okay.
And so once we have a patient like this, once the diagnosis is confirmed, our priority is mainly for anticoagulation.
Okay.
Because our actually prime aim is to prevent further complications of DVT, and the most one being pulmonary embolism.
So in a patient who is having a history of trauma, you don't investigate. Otherwise, what investigation you will send for thrombophilic conditions?
We have to think about all the routine investigations, including like complete blood count.
Okay. Then
peripheral
platelets.
RBCs increased.
Increased platelets, increased RBCs,
or
then
leukocytosis itself.
leukocytosis, then other investigations. They are not routine investigations. Chest X-ray, ultrasound abdomen, chest X-ray for malignancy, ultrasound for malignancies, then
D-dimer,
ECG,
fibrinogen,
fibrin. All these things are for your thrombus. But the cause of thrombus we have to investigate. Homocysteine level, then factor 5 mutation level that we have to send. Except 3 investigation. What are the 3 investigation you are not supposed to send? Protein C, protein S deficiency, protein C, protein S, and antithrombin. All these things will be acutely deficient because body will try to autolyze this thrombus. So we are not supposed to send. Suppose we are sending, then we should not see that if it is reduced, we should not brand him as deficiency state. We have to repeat it after sometimes. Only if the levels are good, then we are ruling out the condition. But if the levels are low, we cannot make a diagnosis. Okay, how do you treat this condition?
The prime treatment is anticoagulation, and if the patient is not having any history of any renal failure or anything, we can start him on a low molecular weight heparin.
Okay, what low molecular weight heparin you start?
Usually preferred is either fondaparinux or enoxaparin. We can use enoxaparin. We can use 1.5 milligram per kilogram. BD dosage we can give.
Okay.
The main idea is to use it as a bridging dosage until we start on a oral anticoagulant like warfarin. Our aim will be to bring up the INR to a range of 2 to 4, that is around 2.5, like that. About 2 we have to.
When you are starting low molecular weight heparin, what you have to monitor? INR.
Along with when we start, same time we start warfarin.
No need to monitor.
A lot about this thing.
You are talking about warfarin.
Yeah.
Okay. So if you are starting heparin, APTT should be monitored. That should be in range of 35 to 70.
About twice the level.
Twice. That means double of the normal.
Double of the normal APTT. And suppose we are starting any low molecular weight, we don't have to monitor anything.
Okay.
But at the same time, we are starting warfarin. We have to warfarin. INR has to be monitored.
Okay. It has to be
therapeutic range.
What is the therapy target INR?
2 to 4. Like about
2.5 to
2.5 to 3.
Okay. Only in valve replacement you require a higher INR, more than 3.5. Okay.
So until this INR level is reached, we continue our low molecular weight heparin. Usually to a day of about 5 days will be required.
Normally it takes 7 days to act that oral anticoagulant like warfarin. Other drugs act very fast. Okay.
And then once the INR level has been reached, then we can actually continue the warfarin orally.
Okay.
And the primary aim is to continue for about 3 months in a like with patient who's having a clear history of any factor that can actually precipitate DVT.
Okay.
Suppose it is an unexplainable cause for DVT, then we have to continue for at least 6 months.
Okay.
And also suppose the patient is having any non-malignancy as a etiology, it's preferably even better to go for a low molecular weight heparin as a continuous treatment for 6 months. Better than more than warfarin.
Okay. If it is in pregnant lady?
Pregnant lady, again we can go for heparin.
Heparin or low molecular weight heparin to be continued. Okay. So you should not put him on warfarin.
Heparin we can actually use either dosage of 5,000 as stat and then again 1,000.
1,000 unit?
No.
per hour.
per hour.
Infusion.
Infusion.
Or 5,000 units TID also, subcutaneous TID also we can give.
Or we can paclitaxel like 80 units per
80
kilogram.
and 18.
80 and 18 we can.
80
80
unit
bolus.
per kg bolus.
18 infusion.
Infusion.
That also we can use. If you're going for heparin, we have to monitor APTT levels, and with low molecular weight, we don't have to bother anything, except if the patient is, we have to check the patient is otherwise he's severely sick or he's having a renal dysfunction.
Okay.
In both these conditions, this is contraindicated.
Oh.
And also, if whether the patient is getting admitted, it is better to go for heparin than this thing, low molecular. And we have also newer generations like our anticoagulants, like rivaroxaban, which we can start immediately on day one itself for this therapy. And then the ones that suppose the patient is having any chance of whether he's having a recurrent DVT in the past and or is in a highly prothrombotic state, he may have to this continuous anticoagulation for lifetime also.
Okay. Especially in conditions like
Malignancy.
malignancy, we treat the malignancy. That is a treatment, not there you use filters. Okay. Hypercoagulable states. Hyperhomocysteine treatment is different. What is the treatment? It is B12. It is B12 and folic acid. But protein C, protein S deficiency, antithrombin deficiency, APLS syndrome, all these things you require lifelong therapy. Okay.
Suppose we are having this thing, thrombus from recurrent episodes of DVT, we can even think about IVC filter to prevent
that is mainly in
malignancies.
Okay, lower extremity malignancies can go to the lungs with pulmonary embolism.
So in our patient, actually, he doesn't have any, he didn't end up in having a pulmonary embolism. So he was initially treated with low molecular weight heparin, and after some observation for a few 3 days, actually he was discharged symptomatically better.
Okay. So when will you call the patient for follow-up? What are the precautions you take when the patient is on warfarin? This patient can come after some days to emergency room, whether it is warfarin or some other oral anticoagulant. Especially warfarin. What are the precautions? Other drugs does not have much problem.
So warfarin chances of bleeding will be high due to the risk stratification. That Hasplit score has to be done, sir. So once you get the Hasplit score, you'll get to know about how bad the INR or warfarin status.
So depending on the INR, you have to adjust the dose of warfarin. That is one thing. That adjustment charts are available in all the textbooks, so no need to worry. So according to the INR, you have to adjust the dose. What else?
History of fall.
Drug interactions. So we are starting so many drugs in emergency room. The patient is on warfarin, digoxin, phenytoin, all these things. When we are starting a new drug, check the interaction. Sometimes the therapeutic level may cross to opposite side, higher side. So it may create problems. So we have to, whenever we start any drug, especially in warfarin, you have to check the drug interaction.
So we can also suggest the patient to always remind the physician about he's taking warfarin.
That is also very important.
Then
Rivaroxaban, anything you want to tell? They are newer drugs.
There are 10
newer oral anticoagulants.
Okay.
Mechanism of action will be like direct inhibitor of factor 10A.
Okay.
So
it doesn't require monitoring like
monitoring is not required. That is very, very important. Okay.
Then suppose the patient is actually ending up in pulmonary embolism, then again actually whether we have a suspicion, the prime diagnostic investigation will be CTPA.
Okay.
And depending on the amount of grading of pulmonary embolism, we can actually initiate our treatment.
Okay.
The treatment will be mainly by thrombolysis.
Thrombolysis. There, thrombolysis is the treatment. Pulmonary
The drug
embolism.
of choice will be alteplase.
Okay.
We usually give 100 milligram over 2 hours we give, in which the 10 milligram will be given as bolus and 90 will be given over 2 hours.
Okay.
And suppose the patient is having recurrent episodes, again we can consider regarding our continuous oral anticoagulant therapy. And also suppose the patient is having a massive pulmonary embolism, we can think about thrombolytic therapy along with this thrombus removal by the mechanical methods also. Thrombectomy can also be considered.
What is VQ scan?
VQ scan basically,
ventilation
the patient is having adequate ventilation, but still again is having hypoxia. We have to think about any reduced perfusion, and which can see in
embolism. There will be like enough ventilation will be there, but because of the embolism, the thrombus there, perfusion won't happen. So
Okay.
there will be VQ mismatch, ventilation perfusion mismatch. So that will be a bit.
So ventilation is good, perfusion
perfusion
is
is low.
impaired.
perfusion.
We
On
usually
the other
say-
side, some conditions can have ventilation bad, perfusion good.
Good.
Where you get like that?
Pneumonia.
Pneumonia. So pneumonia also you get VQ mismatch. Here also you get VQ mismatch. But both are totally different.
Basically, we use nebulized isoactive agents, which can actually create a three-dimensional imprint or an image, which can actually give some idea wherever there is actually any mismatch can be three-dimensionally represented.
Okay.
And this we can give a clinical cue regarding the
So
diagnosis.
what test you should avoid in this pulmonary is DVT. We learn so many tests in MBBS curriculum.
That you press the calf muscle, it will get dislodged.
A Homan sign.
Homan sign is the sign which is explained in all books.
It's
That
a
should
classical
not be
sign,
done.
but it should not be.
Should not be done in a patient.
Should be actually, but it can dislodge the
Can dislodge.
thrombus.
What is the treatment for superficial thrombophthalbitis?
We can
This is
just,
deep vein
topic-
thrombosis. If suppose you get a patient who is having superficial thrombophthalbitis, what you do?
topical heparin.
Topical?
Thrombophobia. Ointment.
It is NSAIDs. Only anti-inflammatory drugs are required and you need to follow up the patient. Very rarely it can spread to deep veins. But we have to follow up the patient whether it is extending or not. But most of the superficial thrombophthalbitis is due to
Improper
IV
Spillage
cannulation.
of
IV cannulation is the most thing. So we routinely apply heparinized ointment or you can go for NSAIDs. That is enough. Okay. Anything else?
Basically, suppose to put it together, suppose the patient is suspecting to be DVT, we assess the condition. One is probability of DVT or not. If it is low probability, we go for D-dimer, and if D-dimer is positive, then we can think about again going for an ultrasound to confirm DVT. If it is negative, then there is very low chance of DVT.
Okay.
And the scoring is high in the initial stage itself, we can directly go for ultrasound and confirm the status. And once the confirmation is done, we can also think about risk stratification for other complications like pulmonary embolism and start the patient on anticoagulant therapy.
Okay.
So the drug of choice will be low molecular weight heparin as a bridging therapy until we get the adequate INR for continuous therapy using either warfarin, or maybe we can start the novel oral anticoagulant like ruxolitinib.
Okay.
But then continuously monitor the patient for any other further complications, and once he is stable, we can either discharge the patient, or even in the initial phase he is stable, we can send the patient home itself.
Okay. So advantage in DVT is most of the patient may not require admissions. They can go home with low molecular weight heparin. Okay. There is advantage of giving low molecular weight heparin because it's a subcutaneous dose,
And
BD dose.
require monitoring.
Advantages are there. The patient want to go home, we can send the patient if there is no major risk for pulmonary embolism. Okay. Thank you.
Thanks.